All right, and since Dr. Seth is not here, I'll introduce the next presentation. So, from urology, our combined round today is a case of RCC with IVC thrombus. RCCs are common, RCC with IVC thrombus is also common. What is uncommon is how this particular case was managed. It would be uncommon across the world, although there are other institutions which have started doing this procedure quite a few years back. But this certainly was the first time we did it here. And Dr. Nayak was the consultant in charge and operated on this patient. I think Nilesh, our fellow, will present.
Thank you, sir. Good afternoon, everybody. The title for today's CCR in urology is Robotic Radical Nephrectomy with IVC Thrombectomy, Pushing the Boundaries of Robotic Surgery. So I'll start with the index case, Mr. N, a 45-year hypertensive gentleman with known poliomyelitis, presented with complaints of painless gross hematuria followed by acute urinary retention, for which he was evaluated in an outside hospital with an ultrasound abdomen that showed a right renal mass of size 6 cross 5 centimeters. The opposite side kidney was normal. He was subsequently referred to AIIMS for further management. Uh, when he presented to us, the biochemical investigations were within normal limits. So we proceeded with the diagnostic workup of a contrast enhanced CT scan of the abdomen that revealed a 6 cross 7 cross 7 centimeter heterogeneous hyperenhancing renal mass in the right kidney with tumor thrombus in the renal vein and inferior vena cava till infrahepatic level. The opposite side kidney was normal. There was no retroperitoneal lymph nodes. The chest and liver was normal, no distant mets. I would like to invite Dr. Siddharth from radiology to further describe the CT scan.
Good evening, everyone. I'll be presenting the imaging findings of this patient. So for this patient, we went ahead with the CT renal mass protocol, which includes the corticomedullary phase, nephrographic phase, and the delayed phase images. In the first row, we have the corticomedullary phase images. In this, we can see that there is a heterogeneous and avidly enhancing ball type lesion seen in the interpolar as well as the lower pole region of the right kidney. The lesion shows non-enhancing areas within, likely suggestive of necrosis. No evidence of fat or calcifications seen within the lesion. There is surrounding fat stranding. There is no evidence of significant lymphadenopathy. Medially, the lesion is extending into the pelvic calyceal system. Oh, medially, the tumor is extending into the renal vein into the infrahepatic IVC, which is seen in the coronal reformatted images. So these are the MIP images in which I would like to show. On the right side, there is two renal arteries and there are two renal veins, and this tumor is extending into the infrahepatic IVC through the superior renal vein. So these are the excretory phase images, which further shows the extension of the tumor into the PCS and the excretion of the contrast into the right ureter. Thank you.
So as per our institutional protocol, we perform an inferior vena cava Doppler 1 day prior to surgery that revealed extension of the tumor thrombus up to the inferior border of the liver. Unfortunately, we don't have the images for the Doppler. So we made the diagnosis for this gentleman of 45 year age with the right renal mass and with the level 2 IVC thrombus. And we planned the treatment for this in the form of a radical surgery and right radical nephrectomy with IVC thrombectomy. Usually we perform this in all our cases, we do it in the open approach. For this patient, we use the robotic approach in this patient. So this schematic diagram, you can see the black laparoscopic instrument, that is the liver retractor. There is a renal mass in the right kidney and a thrombus in the vein extending into the IVC. So this is the thrombus in the IVC, the renal vein. This is the mass. So we perform the radical nephrectomy and subsequently we have to remove this tumor thrombus. So to do that, we sequentially clamp the IVC in the infrahilar part, the contralateral renal vein, and the suprahilar part. Subsequently, after clamping, we make a venotomy and then remove the thrombus and repair the IVC. So I will be presenting a short video The patient was in left lateral decupitous position and ports were placed in the standard nephrectomy pattern with 2 assistant ports. So we started off in the minimal axis milieu. We start off with the mobilization of the ascending colon medially to visualize the kidney and the duodenum. You can see the kidney. This is the kidney and this is the duodenum. We have to perform cauterization of duodenum to displace it medially to expose the IVC. In this case, you can see there are multiple collaterals which we expect in the case of IVC thrombus. And we have to be very careful not to cause any thermal injury to the duodenum, as that can be cause of a very stormy post-operative period. Once we have medialized the duodenum and exposed the IVC, that is where the benefit actually for the robotic approach is. You can see such a avascular loose areolar tissue over the IVC. We have to expose the IVC in its length, cranially, caudally, and medially. So we are, and now just here, now you can just see the glance of a tumor thrombus within the IVC. So we mobilize the IVC in all these directions, cranially, caudally, and medially, and we move on to the, after mobilizing, we move on to the dissection of the inferior pole of the kidney. So you can see the gonadal vein and the ureter. We have to create a plane between the ureter and the psoas muscle underneath. So you can see the ureter is being retracted and pushed superiorly, and a plane is being created between the psoas and the ureter to lift up the kidney and approach the hilar structure. The psoas muscle, you can see over here, is a very important landmark in the minimal axis milieu. And after we have retracted the kidney upwards, we move towards the hilum. As we go and move towards the hilum, we encountered an accessory lower polar renal vein. This did not contain any tumor thrombus. So to approach the major hilar structures, the main renal vein with the thrombus and the artery, we had decided to dissect this carefully and clip it and divide it. So that's what we are doing. We're just taking control with our monopolar scissor behind this accessory lower polar vein. There is no thrombus in this renal vein. So we have to we clipped it and we are dividing it to further access the hilar structures. To do that, in a case of IVC thrombectomy, we usually control the renal artery in the interaortocaval groove. So we have mobilized the inferior vena cava infrahilar part of it and taken control of it with the rubber sling. What helps with this step is to able to retract the IVC laterally and enter this medial part of the IVC, where this is the IVC. The aorta is somewhere in this plane, and we are actually in the interaortocaval groove. And we approach the right side renal artery that you can see here in this interaortocaval groove. This is just below the contralateral renal vein. So we have carefully dissected this renal artery and taken control, clipped and divided it here, because that helps in decreasing the blood loss around the kidney as we proceed with our nephrectomy part. Once we clip and divide the renal artery, we take control of the contralateral renal vein with another rubber sling. And then we move on to the suprahilar part of the IVC to take control of the IVC above the renal hilum. So you see, this is the liver. This is being retracted by an instrument over here, and we are taking control of the suprahilar IVC. So once we have adequately taken control of the IVC in all directions, suprahilar, infrahilar, contralateral renal vein, we dissect the kidney from all surrounding structures so that the only attachment of the kidney is with the renal vein. This is the IVC and the tumor thrombus within it. So we separate the renal vein and the hilar structures with a vascular 45 mm stapler, and we cut this remaining last bit of a hilar tissue, and we bag the kidney specimen so that we can proceed with our cavotomy part and the tumor thrombectomy part. So we are just bagging the kidney and we are pushing it in the pelvis of the abdomen. Now we come to the part of the tumor thrombectomy. So as I explained before in this schematic diagram, what we need to do before start giving the cavotomy incision is to take appropriate control of the infrahilar IVC. It's a sequential control, moving on to the contralateral renal vein, and then finally the the clamping of the suprahilar IVC. Once we have clamped the IVC in all these three directions, we are ready to perform our venotomy and remove the thrombus. This you can see very beautifully, the thrombus inside the vena cava that was delivered after giving an incision. You see, despite clamping the IVC from all directions, there are few lumbar veins that are still draining into the IVC. That is the reason why it is still bleeding at this stage despite clamping. So we ensure that the tumor thrombus is completely removed from the endothelium. And after we do that, there is still some part of the thrombus that is attached to the staple that we fired across the hilum. So to be oncologically safe, we have to then further remove this stapler part because the tumor thrombus is stuck to these staples at that junction of renal vein and IVC. So once we remove the thrombus completely from the IVC and the staple, we have excised the staple, we start with our reconstruction of the IVC with the 5-0 Gore-Tex sutures. These are better than Prolene because they don't have memory and they have a better handling. They aid in a good watertight closure of the cava. So this is the suture line of the cava. You can see the IVC is well distended. There is no leak, no bleeding. And we are just cleaning the area right now. And then we will start with sequential unclamping, the same way that we did the clamping part. So this is the infrahilar IVC being unclamped. Then we move on to unclamping the contralateral renal vein. And then we unclamp the suprahilar IVC. So this is, we've unclamped the suprahilar IVC. We again carefully check for any bleeding after unclamping. The IVC looks well distended. There is no bleeding from the suture line. We bag the tumor thrombus specimen in a separate bag. We place a drain and we retrieve both the specimens through a skin incision. So that's the end of our surgical video. So this was the specimen that shows the tumor in the middle and in the inferior pole. And this is the renal vein that shows a tumor thrombus. Post-operatively, patient was on low-dose inotrope overnight that was tapered over the coming morning. He received 4 units of blood products perioperatively. He was allowed orally on post-op day 1. Drain was removed on post-op day 2. Catheter removed on post-op day 3. And he was discharged in a stable condition by day 4, accepting orally, passing stool and flatus. I would like to now invite Dr. Saira to talk about the anesthetic consideration in this procedure.
Thank you, Dr. Nilesh. Now I will be discussing about the major anesthetic concerns and the anesthesia conduct of this case. As any all the prerequisites of these cases were obtained, there is informed written consent was being done and NPA was being planned for this patient. We had planned for a general anesthesia and adequate blood and blood products were arranged. A standard anesthetic induction was done. The major concerns that we were having was, one was the hemodynamic instability throughout the surgery because of one was the major blood loss, and second one was the IVC clamping, for which we had secured hemodynamic monitoring lines. For a beat-to-beat BP monitoring, we had secured an arterial line, and for vasopressor administration, we had a central line. Another thing that we had a concern was the position of the patient after the docking. We had very limited access to the patient, for which we had preemptively, we had secured all the lines. And the position was made very carefully, and in the lateral position, all the pressure points were padded. And one more emphasis was given to the lower limb, as the patient was a case of poliomyelitis. In the intraoperative course, we had targeted a mean arterial pressure of 65 to 70 mmHg. One is the patient was already in known hypertensive. Second thing was to decrease the perioperative renal injury. And we had encountered an intraoperative blood loss of nearly 3,000 ml initially, which was managed with fluids, which was crystalloids and colloids, and later 2 units PRBC was also being transfused. And also patient had a requirement of vasopressors. Initially, we had been given with the noradrenaline and later was added with vasopressin. Intraoperatively, the total intraoperative time was around 8 hours and 45 minutes, and IVC clamping was around 60 minutes. As the patient was coming down on the vasopressor support and the intraoperative ABGs was fine, the patient was extubated and later shifted to the AB8 ICU for post-operative monitoring. During the course in ICU, we had repeated a POCUS to see for the cardiac status as similar to the pre-op echo. Patient had a good ejection fraction and no RWMA, and there was no evidence of any intracardiac thrombus. And post extubation, the ABG was showing a elevated lactate level of 3.4 and base level -8, which was settled on the postoperative day 1 with a likelihood of 1.2. And the rest of the blood products, 111 was 1:1 was being given in the ICU, and patient overnight was being titrated with the vasopressors and shifted out of the ICU into the ward. Now I hand over to Dr. Nilesh to continue.
So we continue with our specimen. This was the tumor. This was the tumor thrombus in the renal vein. The histopath came with described a clear cell RCC with no sarcomatoid features. The tumor extended into the renal sinus and was in the renal vein and the IVC. So moving on to the literature review, around 4 to 10% of patients of RCC present with the venous tumor thrombus, of which around 1 to 16% the thrombus can extend into the heart, into the right atrium. Majority of these patients, up to 70%, can be cured with a radical surgical intent in the form of a radical nephrectomy with IVC thrombectomy. However, the associated surgical mortality is slightly high, between 2 to 10%. The IVC thrombus usually has two components: a tumor part of the thrombus that grows cranially towards the heart, and a bland thrombus that is below the tumor thrombus that is due to venous stasis. Around 10% of these cases are associated with regional lymph nodenopathy. These patients are to be worked up with a staging workup in the form of a cross-sectional imaging, whether a CCT abdomen plus chest or an MRI with a 2D echocardiogram. And as per our institutional protocol, we do an IVC Doppler for all our cases a day prior to surgery to ascertain the exact level of the thrombus. Surgery for RCC with IVC thrombus is a very complex procedure. The standard of care, I have to emphasize this, is open radical nephrectomy with IVC thrombectomy for majority of cases. However, the robotic assistance in this context is new and upcoming. The level of thrombus has important implications for the technique, and other considerations to take care are the location and the laterality. Usually the left side of the tumors, left side kidney tumors, are less common and more complicated, while sometimes the tumor thrombus may be invading into the wall of the vena cava that requires reconstruction with a graft. So historically, Skinner et al. Performed the first open radical nephrectomy with IVC thrombectomy way back in 1972. The robotic counterparts of these are reported in literature as case series, the first of which was reported by Abaza et al. From the United States, that included 5 patients in 2011. Subsequently, there are many other case series, the largest of which is by Ma et al., who described 20 patients ranging with the level of thrombus ranging from 0 to 3 in 2021. The case series consistently report a significant improved outcome in terms of operative time, blood loss, reduced volume of blood transfusion, shorter length of stay, and fewer overall post-operative complications. The level of thrombus is a schematic diagram. Again, the level 0 is when the tumor thrombus is limited to the renal vein. Level 1 is when it just comes into the IVC. Level 2 is within 2 centimeters of the renal vein ostium, below the liver. Level 3 is near the hepatic venous confluence, but crucially it is below the diaphragm, is level 3. And above the diaphragm into the heart or in the IVC supradiaphragmatic is level 4. So the advantages of robotic approach over a laparoscopic approach is in terms of improved dexterity with the arm and wrist maneuvers of the robot, enhanced visualization and precise detailing, a surgeon-controlled camera, which enables the urologist to perform the surgery with a greater precision, improved retrocaval dissection and control of the infrahilar, suprahilar and the contralateral renal vein. And finally, there is better suturing with the robot. So a couple of years back, we published experience from our own institute. This is up to 2018. We included around 56 patients who underwent open radical nephrectomy with IVC thrombectomy. We reported a good overall median survival who underwent this surgery, and we remarked that a multidisciplinary facility is important to improve the perioperative outcome. Over the years, the number of these surgeries in our department has increased remarkably, with the tune of 15 to 20 cases done every year. So, to summarize, IVC thrombectomy is a very complex surgery, but one that gives meaningful survival. Having said that, the perioperative mortality is higher than routine oncological surgeries in the tune of 2 to 10%. The open approach remains the standard of care. However, the robotic approach is emerging, and the urologist should exercise extreme caution of handling the thrombus because a pulmonary embolism is practically possible at every step of the surgery. So it should be done in selected cases and limited to high volume centers such as ours. So since the title of our CCR is pushing the boundaries of robotic surgery, we understand that CCR we discuss only one case, but I will quickly run through few other short videos where we have pushed the boundaries of robotic surgery in complex surgeries beyond the traditional approaches. So we start with the suprahilar para-aortic paraganglioma, which is the crucial thing is the green colored marked paraganglioma is closely abutting the celiac axis as well as the SMA, the pancreas and the renal left side hilar structures. So we did this procedure in right lateral decubitus position in the standard nephrectomy ports. We started with mobilizing the colon medially to expose the paraganglioma and mobilization of the spleen. There again, you can see the complete avascular plane that is very nicely visualized on the robot. So we, on the left side, we come to the hilar structure, the adrenal vein drains into the renal vein. So we have to clip it and divide the adrenal vein, in this case of paraganglioma, so as to be able to scoop the paraganglioma from under the hilar structures, the left side renal vein and the renal artery, and work our way upwards towards the superior limit of the tumor. Here we encounter multiple feeder vessels. We are working right on the surface of the abdominal aorta. So this is the aorta, multiple feeding vessels directly coming from the aorta that we clip, divide, sometimes suture, and slowly but steadily, after controlling as much bleeding as possible, we were able to remove the paraganglioma tissue completely, and that's the end of it, of the tumor, where you can we bag the specimen, and that's the abdominal aorta. This is the liver and the spleen and the pancreas and the kidney and the hilar structures on that side. This another case, 26-year gentleman with mixed germ cell tumor post chemotherapy with residual retroperitoneal lymph node mass. We performed a robotic retroperitoneal lymph node dissection, where we started with incising the root of mesentery and exposing the retroperitoneal structures. There you can see the duodenum. We retract the mesentery superiorly to expose the major vessels completely, and start with a dissection of the lymphatic tissue around the major vessels, the IVC and the aorta. So that's the ureter that forms the lateral limit of our dissection. The dissection continues in the interaortocaval groove between the IVC on one side and the aorta on the other. This again, in this area, all the collaterals, all the feeding vessels are directly from the major vessels. So it is like walking on a landmine. At any step, you have to be you're very near a very catastrophic complication. And so this we proceed towards the upper part of the dissection, towards the hilar tissue. And this is the surface of aorta. This is the inferior mesenteric artery that we're removing the lymphatic tissue from around it. And that marks the that marks the para-aortic lymph node. Usually these tumors are a teratoma post-chemotherapy. So they need to be excised because otherwise they can form a growing teratoma syndrome. So this is the para-aortic lymph nodal mass. So once we are done, we see we are working in the IVC, aorta, intra-aortocaval tissue and the duodenum above. So this next case, 35-year hypertensive diabetic gentleman who presented with bilateral non-obstructive large staghorn calculi, underwent right side robotic pyelolithotomy. We don't have the video for this. I will be presenting this video for doing this left side pyelolithotomy. So we started off with the pylotomy part, and the initial part of the stones, they quite easily they will come out. This is not really a problem. And the reason to demonstrate this video is because this part of the stone, that was a dumbbell stone that we were unable to take out from the superior calyx. So we had to employ innovative endourological maneuvers to take care of this stone. So this is a pneumatic lithoclast that we are breaking the stone, and we usually use this in a PCNL or a bladder stone in endourology procedures. So we thought we'll use it in the robotic milieu as well. So it took care of most of the part, but in the cave of the superior calyx, even the lithoclast was ineffective. And therefore we had to use this holmium YAG laser to dust and completely remove the superior calyx part of the stone. And subsequently, we carefully removed every little part of the stone and retrieved it in a bag and closed the pylotomy over a DJ stent. And finally, this last case, Mr. N, 37-year diabetic hypertensive male who presented with hematuria. And on evaluation of the CT, it was a completely endophytic renal mass. This is the mass. There is practically no exophytic component of this mass. He was referred to us from from a corporate hospital because he was because of the complexity of the surgery. So after the clamping of the hilar structures, again just a very short video, clamping of the renal structures, we used the intraoperative ultrasound to mark exactly how deep the tumor is going, and then we start with the incision and the enucleation part. While enucleated, we realized that the tumor was probably very close to a pelvic calyceal system, so it was opened. So we had to repair that pelvic calyceal system. You see the tumor is completely perfectly removed. The histopath has no margin positivity. The PCS was repaired, and then the rhinography was initiated. In this case, we also unclamped the hilar structures only after the first layer of the rhinography. And subsequently, we moved on to the second layer of rhinography, and we completed the procedure. So to give a message is that in these recent years, we have actually been able to push the boundaries of robotic surgery into very complicated, complex procedures that are different from the traditional way of operating them. I thank you all for your patient listening, and I welcome all questions. Thank you.
So, thank you. So, as Nilesh has pointed out, IVC thrombus is actually very challenging surgery that can have, if you do not have lots of experience, these patients can have significant bleeding because IVC is completely occluded. There are lots of collaterals around renal, kidney, and also around the mesentery. So, by the time actually you reach and do a nephrectomy, you must have lost significant amount of blood even before you open the IVC. So, it's always a challenging surgery. And most of our cases we routinely do by open approach. The only thing that we decided to choose this case, it's not like this is a new case and nobody has done it. People have done it outside. And there are different series of IVC thrombectomy. So this was our first case in our hospital. So we decided to discuss this. And also to give a message, IVC thrombectomy should never be attempted with robot unless you have a significant experience of doing challenging surgery and also by open surgery. and your threshold to open up also should be very low. You should not persist. If you are finding any difficulty, you should not persist just for the sake of doing it by minimally invasive approach and compromising with the patient's safety. And during the surgery, I think the anesthesia role is actually significant, which is not, most of the time, it's not emphasized. Because anesthetists, if they keep on, because there are anesthetists who will actually keep on telling you during surgery, the patient has hypertension, he's having significant blood loss. If they actually persist you, then you actually become more panic during surgery. So what we have actually very good anesthetists with us, they never tell you during surgery, at least the team that we work on, they never interfere. This patient is having hypertension, having significant blood loss. They manage their part. Even if this patient actually has a significant 3 liters of blood loss, during the surgery, they never told us this patient is already on inotropes. In fact, actually, before we operated this patient, Dr. Rasmi we decided whether we should do it or open or robot. I was discussing with Dr. Rajiv, sir, करना है क्या इसको नहीं करना है. तो डॉक्टर रसीम बोला कर लो. मैंने तो ये तो 100% ओपन होगा. Dr. Rasim said, no, I have seen you guys operating, you will be able to manage it. So somehow actually, thanks for the confidence on us. But the message is actually, with robot, there are many complex surgeries which usually we do with open approach, like RPLNDs and IVC thrombus. IVC thrombus, though we have done only one, but RPLND we have done quite a few patients with the robotic approach. With robot assistant, these complex surgery can be done only if you have significant experience. But the message again is these should not be the standard of care. Thank you.
Also glad to see all the other extras, which are advertisements. Yeah, I just wanted to see these are things we would not do laparoscopy. The classic argument against the robot always is, why don't we do it laparoscopy? So these were some things we would not have done laparoscopy. They would have been difficult to do pure laparoscopy. So it makes sense to do them. 20 years. 20 years. Exactly 20 years. What more experience?
Yes. Thank you, sir. Yes, absolutely. No doubt on that.
That's why he's absolutely right. अगर दूसरी साइड से और 500 चला गया और 500 चला गया, then you say छोड़ यार खोल देता हूँ. Here we don't get that.
This case, because this was infrahepatic and it was a right-sided tumor, and the tumor was not very bulky. The tumor was confined to the kidney and it was not very bulky tumor. So too easy to start with. Level 2.
We could have saved a couple of liters possibly if we had clipped the
Lumbar vein. Lumbar vein, yes.
We did not realize that. It was easy. We could have done it very easily. It just didn't strike us that that will also possible. But we could have saved a liter and a half to get the slip.
To radiologist also, looking at intraoperative, very navigating all those steps is very engaging. First, I had a couple of things to ask you. What was the position of the operative position of a patient?
Patient was lateral position, right, left lateral, right side up.
Even though surgically, do it with a lot of release, but eventually, as I understand, led to prolongation of a surgery time. Is that right? Because it took almost 9 hours.
By 6 o'clock we finished. Usually IVC thrombus also, if you would have done it by open, I agree, maybe you would have finished by 3:30, you would have finished. So it took another 2 hours maybe in this case. Yes. Yes.
Should not take this.
The benefits of it are more, so much more than
Here, both things need to be improved. Our operating time was too long, our blood loss was too much. This is not acceptable. But then this is the first. Similar. And our target should be an operating time no greater than open surgery, blood loss less than open. That has to be done. We haven't done it, and this is the first. We've identified where we've made errors and where we need to improve. So hopefully next.
The perioperative mobility, as we have shown in that study, that is spanning from 2008 to 2012 years, it is 9%. So is it any different in last 5 years?
The perioperative mortality mostly actually all these patients, if you manage them intraoperatively well, they will actually get through. Sometimes they will have chest infection or some sort of thing, so they die perioperatively. And some of them actually will have pulmonary embolism. We have actually lost few patients because of the pulmonary embolism intra-op. Very recently also there are two patients. One Dr. Seth was operating. She had pulmonary embolism. She had persistent hypertension, and then post-operatively we did a CTPA to confirm embolism, and then she was shifted to the CTVS in the same night, and she was done pulmonary embolectomy, and it was revived. And just maybe 10 days ago, I did one case in CTVS. The patient was done in CTVS. The patient has actually renal vein thrombus, left side tumor, renal vein thrombus, extending till the right atrium. The tumor was already in the right atrium. But when I did a nephrectomy, I put the clamp on the renal vein and detached the specimen. That point in time, the complete thrombus, even though that was there in the RA, right atrium, all actually embolized in the pulmonary artery. The patient had sudden hypertension, and in fact, he had asystole for 1.5 minutes. I had to do cardiac massage there in the CTVS OT, but immediately within 2 to 3 minutes, the CTVS team, they opened the chest and then did pulmonary embolectomy, and the patient is already gone home. Now he's okay, he's gone home. So this embolism can happen anytime during the course of the surgery. It's actually, that's the reason it's very risky to deal with these patients.
Related to the level of the thrombus, a level 2 thrombus should not have a negative mortality unless they've embolized, in which case any level would go. But level 2 typically should not have mortality.
That has happened in the space of PSRs. When we do this therapeutics, we mostly do it in advanced stage, those who are stage 4, but with the IVC thrombus. The reduction in thrombus with just one TKI, with one tablet, it could be somewhere around 50%.
So actually, no, there are case reports. It's not like if you give this immunotherapy and TKI, there will be significant reduction in the level. But there are reports actually, if it is level 3 or level 4, if you give it for some time, then it can reduce your level of the thrombus. There are reports. It's not like all patients you should give these TKIs and immunotherapy preoperatively. Maybe, yes.
Undoubtedly.
Yes.
Yeah.
But the IVC thrombus patients, once we see them in the OPD, usually the patient gets admitted within a week time and then get operated. We don't give them a date. But if you give these patients TKIs and all, we do not know who are the patients likely to respond. By that time, the patient actually had embolized and can happen those things. So IVC thrombus, we usually don't recommend unless the patient is unfit for surgery. Then you give them TKI or
So
immunotherapy.
TKIs have that small additional disadvantage of poor healing. When you add TKIs, particularly if it gets prolonged, and the shrinkage of tumor well documented but requires prolonged therapy. It won't happen over a week. You'll need to give it for a longer period of time before it comes down. And while you may say that there's no harm in starting, which may be true, if you're giving it for that long, you're also risking poor healing of the tissue. So it's a fair game. If you're able to operate safely, you'd say I'll operate. If you believe it's going to get delayed or they have comorbidities, then do the TKIs first. There's a big difference.
Yes.
And if you have time, otherwise 2 weeks of TKIs may not actually bring down the level enough. You probably need it for longer than that.
Yes. I don't think there is any imaging they can tell these are very organized thrombus or there is a fibril thrombus from imaging, whatever MRI or CT, they cannot tell. These are thrombus which are. Yes.
which we can say with relatively more confidence. Otherwise, if it's stuck to the wall inside, that's not easy.
It's difficult to tell, yes.
Filters, infrarenal, suprarenal. Certainly, this setting is different. So, has there been any literature in which the IVC filters will take care of it? Embolization of
These actually have been discussed multiple people, those who are doing in international level also. Nobody routinely puts IVC filter for IVC tumor thrombus. Yes, yes, yes.
Once you have a thrombus, operating becomes difficult. You can't put a clamp where the filter and population. So the filter occupies 3 to 4 centimeters of the length of the cava. You lose that now, and you have to go higher. And removing that filter sometimes is very difficult.
Yes, yes.
Claws go into the wall on the side. So you pull it up from above. You pull it from above. So theoretically, there's going to be a delay to put this.
just general. So, in terms of the logical we are doing on the topic, looking at only less morbidity, but they're also going to see better
Oncological outcome, there is not much difference between open surgery. It's actually the perioperative patient recovery and morbidity, yes.
Outcomes, nothing has shown to be better. No robotic surgery has shown better outcomes. It has shown better outcomes when surgeons with lower competence and lower volumes perform laparoscopy versus robotic. So a surgeon with low volumes doing laparoscopic partial versus robotic partial, his robotic partial outcomes are better. A surgeon with high volumes and does laparoscopically regularly has no worse outcomes than robotic. So it's got a lot to do with volumes and many things. They've taken towards. Thank you. Thank you, sir.
Well done.